going to turn to several talks that will address the data for several new agents in this setting. And the first of these, I want to welcome Ingrid Mayer, who's now with AstraZeneca, and she will just provide insights into the adjuvant data for CDK4/6 inhibitors.
Thank you. So first of all, good afternoon. It's such a pleasure to be here today live, despite the room being a little empty. Still gives the feeling that talking in person is a lot better than taping something on Zoom. So I would like to thank the organizers for inviting me to do this talk today. So these are my disclosures. Estrogen-positive cancer by far is the most common cancer that we see when we're dealing with breast disease. It comprises almost 70% of the patients we see in clinic. But there's a wide variability of how endocrine sensitive these patients are. There's a clear correlation between the level of expression of ER and PR and response to endocrine therapy. And even from a biological prognostic and predictive behavior, we could segregate ER-positive cancers into luminal A's, which are the quote-unquote well-behaved endocrine-sensitive tumors. They tend to have lower grades and higher expression of ER-PR. And luminal B's, which are those cancers that clinically present more like those high-grade tumors with lower expressions of ER-PR. And perhaps most importantly, I think what we have to acknowledge is that from an overall clinical behavior, these are the cancers that, despite getting the reputation of having good clinical outcome overall, are the ones that can have very late recurrences, which still plague and kill the majority of patients that die from metastatic disease today. So in metastatic setting, in addition to the well-established endocrine therapies, we now have shifted to add targeted treatments to circumvent both primary resistance to endocrine therapy and acquired resistance to endocrine therapy, which fortunately is the most common one. Notoriously, CDK4/6 inhibitors have shifted to the treatment of ER-positive metastatic breast cancer in the first and second line treatment, not only in the US, but across the world in several places. So that's what we're going to talk about today. There are 3 currently approved in the US CDK4/6 inhibitors: palbociclib, abemaciclib, ribociclib. Many of you have heard me refer to them as Coca-Cola, Pepsi-Cola, Dr. Pepper. But nevertheless, indeed, they are very similar in their mechanism of action, but they're not identical drugs. They have different administration schedules. Abemaciclib is different than palbo and ribo by the fact that it's being given continuously. Part of that is because it's not as myelosuppressive as palbo and ribo is, so you don't need that week break in the administration. But it is also the one CDK4/6 inhibitor that is associated with some GI side effects, which palbociclib and ribociclib typically don't have. So they're very similar drugs, but they're not the same drugs. However, from a clinical efficacy point of view in the metastatic setting, these drugs are remarkably consistent. The second-line data, which I'm not showing you here, has consistently shown improvements in progression-free survival and overall survival for all 3 CDK4/6 inhibitors. And in the first-line treatment, all 3 CDK4/6 inhibitors were associated with a doubling of progression-free survival advantage, and at least one of them has already reported overall survival data for both pre- and post-menopausal women. In this case here, the Mona Lisa trial done with ribociclib in addition to letrozole, showing quite unparalleled overall survival advantage. Obviously, with all this data, the enthusiasm to transition these drugs to the early setting came about, and several clinical trials in the adjuvant setting were designed to address if the addition of these drugs to adjuvant endocrine therapy could reduce morbidity, mortality on patients with high risk of recurrence of ER-positive disease. So let's take a look at the 4 clinical trials that have been designed in this setting. 3 of them have reported results, 1 of them have not, and I'm not going to talk about it today. That is the NATALEE trial. These 3 clinical trials, despite having a very similar design, meaning adjuvant endocrine therapy plus minus CDK4/6 inhibitor for a given amount of time, followed for invasive disease-free survival, there are some differences that go beyond just the choice of which CDK4/6 inhibitor is being added. Let's take a quick glance at this table, and then we're going to do a little bit of a deeper dive on each of these trials. Let's start with Penelope B. That was the smallest of the trials, and that actually selected a patient population that was exposed to neoadjuvant chemotherapy, didn't have a complete pathological response, and had what we call a clinical pathological score that was higher. And what clinical pathological score is a way to provide prognosis after the use of neoadjuvant chemo. So it takes into account how the clinical stage was at presentation, what pathological stage the patient had at the time of surgery, what grade the tumor was, and how, like, if ER was positive or negative. So as you can imagine, the higher the score, the higher the clinical risk. So Penelope B selected patients based on anatomical and biologic risk characteristics by selecting patients with a clinical pathological score EG3, or in the case of clinical pathological score EG2, they had to have positive nodes at the time of surgery. Penelope B treated patients with a CDK4 inhibitor for 1 year. Pallas and Monarch treated patients for 2 years with CDK4 inhibitor. The big difference between these two trials that have a similar number of patients accrued is that Pallas selected patients based on anatomical high risk, meaning patients that had stage 2, either stage 2A, which was capped at 1,000 patients, or stage 2B or stage 3, but did not select patients necessarily based on biological risk criteria, like grade or Ki-67 or whatnot, which was the case with Monarch E, where patients had to have positive lymph nodes in order to come into the trial. And if the lymph nodes were between 1 and 3, they also had to have either high grade, large tumors, or Ki-67 more than 20%. So let's take a look at the Pallas trial first. So again, large trial, endocrine therapy plus minus palbociclib for 2 years. Invasive disease-free survival is the primary endpoint. When you look at the patients accrued, I think two things struck out. One is that a good proportion of patients had stage 3 disease. So almost 50% of patients had stage 3 disease. So that's good, because this clearly is a high-risk patient population. But when you look at grade, the vast majority of patients had either grade 1 or grade 2 disease. So one could conceive that biologically, this is not necessarily a super high-risk patient population. So there's potentially a blend here between patients that are high risk and patients that are not so high risk. Unfortunately, when you look at the final outcomes, and now we have completed a follow-up on this trial, neither invasive disease-free survival or disease relapse-free survival were impacted by the addition of palbociclib to endocrine therapy. And that was unfortunately also in all subgroups and really independent of clinical risk. When we look at how many patients actually completed the planned treatment, there was a high rate of discontinuation, where about 40% of the patients discontinued prematurely. It's tempting to think that that may have accounted for why the trial was negative. However, with longer follow-up now and longer palbo duration, when you actually hone down on the patients that had more than 70% dose intensity, the outcomes were no different. So that really is not a good quote-unquote excuse for why the trial did not perform. Penelope B, as I said, is a little bit different, in which the randomization of patients was only for 1 year for the addition of the CDK4 inhibitor. Here, the patient population, as I stated before, was a blend between anatomical high risk, but a little bit more enriched for a biological high risk, where about a fourth of the patients had Ki-67 more than 15%, and almost half of the patients in the trial had grade 3 disease. Initially, the results seemed promising at the 2-year follow-up mark, where there was a clear separation of the curves favoring the addition of palbociclib. However, with longer follow-up, and now we are looking at 4-year invasive disease-free survival, the curves come together, and there's really no benefit regardless of subgroup analyzed. The treatment discontinuation here was not much of a problem. About 20% of patients discontinued palbo prematurely. And finally, looking at the Monarch E trial, the trial that selected patients with the highest risk, both from a clinical pathological criteria, but also from a biological criteria, enrolled patients in 2 different cohorts, which are kind of like half and half split between the trial. First cohort was based on clinical pathological features that included more or equal to 4 lymph node involvement, or if 1 to 3 lymph node involvement, patients also had to have grade 3 disease, as well as a tumor size more than 5 centimeters. Cohort 2 did not require more than 4 lymph nodes. Patients could have 1 to 3 lymph nodes. They could not have grade 3 or tumor size bigger than 5 centimeters, but they had to have tumors with a Ki-67 more or equal to 20%. They were randomized to receive abemaciclib for 2 years, in addition to endocrine therapy, and the group with high Ki-67 comprised about half the patients in the trial. When you look at the patient characteristics here, you see a little bit more of a shift towards the clinical characteristics that are high both from a pathological view and a biological view, where about half of the patients had Ki-67 more or equal to 20%. So let's look at the results. So what you see here is that from a primary endpoint point of view, this was not only statistically significant, but clinically, we see that the addition of abemaciclib to endocrine therapy did have an absolute difference in invasive disease-free survival that equal to 5.4% at 3 years. And disease relapse-free survival, the absolute difference there was 4.2% at 3 years, making this not only statistically, but also clinically significant. When we look at subgroup analysis, no particular group benefited more or less from abemaciclib. The benefits seem to be across the board. And I think what was mostly reassuring, which a lot of us was concerned about, was the potential phenomena that happened with the Penelope-B trial, where the curves after longer follow-up closed. But this did not seem to be the case here for the Monarch-E trial, where even with longer follow-up, the increasing magnitude of invasive disease-free survival and disease relapse-free effect really seemed to stay maintained throughout the time and persisted beyond the 2-year mark of the treatment period. When you hone down in the patient population that was high risk biologically, meaning the ones with Ki-67 more or equal to 20%, you see that the absolute difference in invasive disease-free survival rate here is larger, is 6% at 3 years. And when you blend that with high risk from a clinical pathological point of view, so these are patients with larger tumors, more lymph nodes, and Ki-67 more than 20%, that's when the benefit is the highest at 7% at 3 years. So this is a snapshot of what we're looking at right now. So you have 3 trials that reported, Penelope-B, Pallas, and Monarch. Each one of them had a different CDK4 inhibitor. At least Penelope-B Pallas was Palbo, but Monarch-E was Abema. The key eligibility criteria is different between the trials, so we are not talking necessarily about the same patient population. And discontinuation rates, despite being a little different in Pallas than the other 2, really did not seem to account for differences between the trial. I think, in my opinion, I think the biggest difference that we see here really boils down to the eligibility criteria, where a higher risk patient population really may have accounted for the benefit that is being seen with Abema versus Palbo. But nevertheless, I think what we need to focus on is who are these high-risk patients that are truly benefiting from this. So there's no doubt that the patients that have high Ki-67 beyond 20% are the ones that had the highest magnitude of benefit looking at invasive disease-free survival at 3 years. But you look at the far right of this table on the bottom, when you look at the patients with Ki-67 less than 20% in cohort 1, which was the one that mostly was similar to what was enrolled in Pallas and Penelope, the benefit is there as well. The magnitude is not as large, but proportionally is there, and it is statistically significant. So how do we conclude this talk then? Are these drugs ready for prime time? Seems that they are, because the addition of 2 years of abemaciclib to endocrine therapy received FDA approval in October for patients with ER/PR-positive breast cancer, both pre- and postmenopausal, that had high-risk disease. And that was defined as anyone that presents with more or equal than stage 2B breast cancer with Ki-67 more than 20%. So, when we look at this statement, sounds good, but I think there's some key questions that we need to pay attention to. One is a pragmatic one. So we have a test, Ki-67, that many of us see in our pathology report. But the approval of this drug came with a companion diagnostic, and technically this Ki67 should be done centrally. But is that really feasible throughout the world, throughout the US even? Or can we rely on local testing? And we know that there's a big variability on how people read and look at Ki67. So are we running the risk of over-treating or under-treating patients based on that? The other consideration is a lot of patients sometimes that are high risk anatomically are being treated in the neoadjuvant setting with chemotherapy. So which Ki67 are we going to rely on? The one that was done in the core biopsy or the one that was done in the surgical specimen? And is there a difference? Furthermore, there are a lot of patients with stage 3 disease, anatomically speaking, that don't have high Ki67. And a good example that comes to mind are the lobular cancers. They are high-risk disease of recurrence, but biologically they're not that aggressive. These are potentially more indolent tumors. So does that mean that they don't benefit from abema? I don't think so. I think they do. These patients are excruciatingly high risk of recurrence. And I think that considering what we've seen in the previous table, where the patients that had Ki67, less than 20%, still derive proportional benefit from abema, I personally would consider offering abemaciclib to someone with stage 3 disease despite not having Ki67 over 20%. And I think the final question on how to reconcile this in the clinic is, what do we do with that patient that comes in, has high-risk disease, but also has a BRCA mutation? Because now we have olaparib available in the adjuvant setting. So do we give that patient olaparib, or do we give that patient abemaciclib? So this is kind of like something that I drafted sort of in my head and put it on paper of how would I use this in the clinic. So as I mentioned before, the patients that I've offered abemaciclib to would be the ones that have at least stage 2B and above disease with Ki67 more than 20%, but I would also consider this for high-risk patients that have stage 3 disease, node-positive cancer, despite not having Ki67 as well. And I think I was not the only one that had that impression, because it sounds like the ASCO guidelines, the most updated version came out in November, does agree with me, and I do have that snippet in there on the side. I know it's small to read, but I encourage you to look at the publication. But again, what do we do with patients that have the BRCA mutation, where they potentially could benefit from both drugs? Which one do we choose? Or do we choose both and use them sequentially? So I don't think we can compare apples with oranges. Here, I think a lot of us would potentially be tempted to offer both. Maybe in a perfect world, if toxicity was not an issue, one could conceivably think that you could treat someone with olaparib for 1 year and then segue with endocrine therapy and abemaciclib. The problem, though, is that I don't know what that's going to translate into, not only in short-term toxicities, because all of these drugs are myelosuppressive, but most importantly, someone with a BRCA mutation is bound to be a younger patient. So technically, if that patient does not have a recurrence and die prematurely, is going to have a long life ahead of her. And these long-term hematological toxicities in the bone marrow are really quite unclear how they are going to shape up. How do we know that using olaparib followed by abemaciclib is not potentially going to increase the risk of leukemia? Who the hell knows? So I think all of this needs to be discussed very individually if you're going to use one drug or the other, or both sequentially. And I'm certainly not suggesting that people need to do that, but I think that is a very individual discussion based on risk, and we don't know quite yet what to do. I think for premenopausal women, the algorithm looks a little bit different, but when it comes to abemaciclib and olaparib in special circumstances, we fall into the same category where, again, we would consider abemaciclib for patients with stage 2B disease with high Ki67, but also patients with stage 3 disease as well. And finally, other important considerations in this topic: will the addition of abemaciclib at the end of the day really translate into overall survival advantage? The reason I ask this is because that was the first thing on my first slide. Late relapses are a real deal. And to me, that's the biggest unmet need we have in the early setting. The older I get, the more I realize that after 20 years in practice, patients that I treated 20 years ago with stage 1 disease today are coming back with metastatic cancer. And what do we do for those patients where this dormancy of the tumor is a big deal? And will this use of CDK4 inhibitors in the adjuvant setting, Will they address that? The other thing to consider is toxicity and quality of life. 2 years of abemaciclib, while it's not poorly tolerated, may come with an impact, a negative impact in quality of life. We already have issues with adherence with endocrine therapy alone, especially in younger women. When we are adding these drugs, we are adding a whole new level of complication of day-to-day increased fatigue, having to deal with blood counts, potentially having GI side effects and so forth. Not to mention that there are some rare side effects like thromboembolic events or interstitial lung disease that fortunately we don't see often. But if we see that in the early setting, that's obviously a much bigger deal than dealing with that in the metastatic disease. Also, we are now in flux where we're seeing the appearance of new endocrine agents in the mix. You just saw in the previous sessions elegant presentations on all these new drugs, salad of words, SERMs, SERDs, SERCAs, PROTACs, et cetera, et cetera, et cetera. They are bound to transition to the early setting at some point. And if they do, how will they change this impact of CDK4/6 inhibitors? But I think the big take-home message here that is a win for everyone is that there are more options for patients, and slowly but surely we're making advances in how we treat ER-positive disease and at least minimize the risk of recurrence for a good proportion of patients. And all the translation correlative work that has been collected in all these trials with all this biospecimen collection, I think are a gold mine for discovery on how to better select patients for treatment and how to better select patients for future clinical trials as well. And with that, I would like to say thank you again for the organizers. Thank you all for being here and listening to this, and I guess we'll have questions later.